Hello, good morning. There we go. Okay, so this section right here, which was number 3, which was minimum alveolar concentration, it's referred to as MAC. Every inhalant agent is assigned a MAC, which is the percent of agent where 50% of patients will not respond to a painful stimulus. And the goal of knowing, that tells you how potent, how much of that agent are you going to need to keep them asleep? Now, again, when they studied MAC, it was the painful stimulus is like, I think it was like pinching a toe. It wasn't like full abdominal surgery or a neuter or extractions. So, that number, where it is a guideline, they didn't have anything else on board. It was the sole agent. So number one, when you use pre-med and induction agents, it's going to alter your MAC percentage. Ideally, our pre-meds are MAC sparing. That's the goal of giving pre-meds and induction agents, is not using as much of your inhalant, And so let me start with halothane. Now, halothane, which its MAC is 0.76. So they said, that'll keep about 50% of your patients if you have them at 0.76% on the vaporizer. Now, you can't use this one anymore, so it's not commercially available, but it'll probably be on the board exam. It had, even though halothane, yes, Kayla, pre-meds lower your MAC. So that's how they affect your MAC, is they do lower it. But halothane, it was a volatile agent, so it needed a precision vaporizer, but it had a slower induction and slower recovery. The ones that we're really comparing are halothane, isocevo. So out of those, this one has the slowest induction and slowest recovery, because part of it's because if I go back to blood gas solubility, it has a higher blood gas solubility. So halothane does get absorbed into the tissues, into the rubber parts of the anesthetic machine, like the tubing and the plastic. It's rubber soluble. So the problem is, to get a high enough concentration to the brain rapidly, if it's starting to move into compartments, if you think of it that way, when you give a dose, some of it's going to the tissues, some's going to the rubber. So to get a high enough concentration of the brain rapidly, it takes longer. And that's where solubility, remember, solubility tells us speed. So that's where this is. And the other thing with halothane, it did require some liver and kidney metabolism. So if you did have a patient with liver, elevated liver enzymes, you might want to choose another agent, or you may want to try to use a lower amount if possible. Now, one thing I will tell you, this sentence, it says you do not need a precision vaporizer, but it often was used in a precision vaporizer. When I get into vaporizers, you could use it in the older non-precision vaporizers, but then they did develop a vaporizer for it. And that's where the percent comes in, and I'll explain that when I do vaporizers. It does sensitize the heart to arrhythmias, meaning it makes it more readily a patient could have an arrhythmia. So if I had a patient that had a pre-existing arrhythmia, sometimes trauma patients come in, have an arrhythmia, sometimes animals with heart disease have a pre-existing arrhythmia, it could make that worse, it could make it more apparent. So we use this agent with caution. Obviously, if I have another agent, I would use a different agent. If halothane was my only agent, I'd be watching that EKG very closely, may have to treat an arrhythmia. Now, isoflurine's the one I talk about the most, because that's what everybody's really using currently. Isoflurine, when it came around, it's a highly volatile agent. It definitely needs a precision vaporizer. And remember, I said if you put isoflurine like on a cotton ball, in a mask, or like in a jar, open to the air, you could reach up to 30% isoflurane. We only deliver 5%. That's the max what we deliver. So you can see that means it's volatile. It wants to turn to a vapor immediately. I mean, if you left the bottle open and you came in tomorrow, it'd be gone. It would just turn to a vapor and be gone. So, but it is associated with a quicker induction and a quicker recovery. And also what I don't want to neglect to admit or to talk about is this also means you can change your patient's planes of anesthesia. So if you think about planes of anesthesia, okay, and remember when they go to sleep, they're at stage 3, plane 1, and then you put them on the gas and they start to go down to stage 2, which is where you want them. But then they go to stage 3, stage 4, like they keep getting deeper. You can turn it down and you're going to get a more rapid, they're going to come up out of that deep anesthesia quicker. So you can make fine adjustments and maybe see a difference in like 2, 3, maybe 5 minutes, because if I have a student and they're like, okay, my patient's deep, I don't like their respiratory rate, they seem really deep. And one of the first things I'm like, turn down your vaporizer, give them less gas, and you should see them change. So it gave flexibility. It is minimally cardiovascular depressant, except at the higher doses. So it can, when you are running percents higher than 2.5%, you're going to see more of a likelihood of hypotension. It is a vasodilator. That's one of the things I don't like about the inhalants. I mean, you can't get away from that effect, but they are everyone thinks they're safe. Everyone, if I had a dime for everyone, said it'd be safer just to mask this dog down, I just want to smack him. Because I'm like, no, because you're going to have to use much higher dosing if you don't give them any other drugs, and then you're going to see more of this respiratory depression, hypotension. So I will tell you, in addition to the cardio depression, it's a respiratory depressant, but they're asleep. They're going to breathe less often, and they're going to breathe less deep. But again, anytime you start going above 2.5%, that's going to be worse. More respiratory depression, cardiovascular depression, especially the hypotension. It is good for mask and chamber induction because it's quick. I mean, definitely if I had iso and halothane, I'm picking iso because, that's not a pleasant, and when I say chamber induction, if you're not familiar with that, there's something called a cat box. Some people call it a kitty aquarium. It looks like an aquarium. And if you have an aggressive cat, and I will talk about this when I do equipment, but you put the cat in the box and then you hook up the gas and they inhale the gas. It's like a little gas chamber. And then when they fall asleep, you can get them out. I had a really aggressive cat that we had to radiate. I mean, the lady, we would take the aquarium into the room with the owner. The owner would put the cat in the box for us. And then I'd carry the box and the cat is hissing and spitting and hitting the aquarium. But I'm like, you can't get me. I'd hook up the gas, cat would go to sleep, do radiation. When the cat was half away, when I'd recover, I'd put the cat back in the aquarium, or I'd get the carrier from the owner. I'd put the cat in the carrier, and then when she was growling enough, I'd take her back to the owner. We did this 22 times because the cat got what's called definitive radiation. She loved that cat. But, I mean, so we did this daily. Put the cat in the box, and because really just getting an injection and, chamber induction though is very stressful. I'm not a huge fan of it. There's some people that won't do it at all because they can bang around in the chamber, but it sometimes is done, and I'll talk about that. The nice thing is there's almost no organ metabolism. This agent, the way they get rid of this drug is they exhale it. So if they have liver or kidney issues, it's not taxing on the organs. So primary route of elimination is just to exhale it into the recovery area. And one thing I should mention that's not on here as a side note, if you think, sometimes if you think you're pregnant, or, you're trying to get pregnant, or sometimes when you initially find out you're pregnant, and this is just a little one-on-one, you don't necessarily want to tell everybody, but exposure to inhalant agents, you have to be very careful. The iso and SIBO are fairly safe. if you inhale them by accident. But one area that especially pregnant women, everybody forgets about recovery. So if you're in a recovery room, and when I was at Purdue, I might have 4 patients recovering at the same time, and I'm in that room, they're all exhaling gas. And so, and you're technically exposed at 5 parts per million. You can't smell it until you're 50 parts per million. So sometimes people are like, oh, I can't smell the anesthetic, because it does have an odor. But by the time you smell it, it's already 10 times your exposure that you're supposed to be exposed. So I always caution people that, you know, because sometimes you don't want to tell people. I mean, the first people, before my mother even knew I was pregnant with my daughter, my anesthesiologist at Purdue knew, because I had a teaching lab, and I was like, I'm pregnant. And he was like, then you're going upstairs and doing paperwork, and you are not going to be down here. So, you know, you don't want to forget that when they're exhaling these agents and you're down here, and you have to kind of be close to them. You know, yeah, I mean, you just have to know, you know, but, you know, you're really close to the animal. You can't really be far away. So it's just something to think about, something to keep in the back of your mind. Isoflurane's MAC is 1.2% in the dog, and I want to say it's around 1.4 to 1.6 in the cat. But again, I'm going to talk about how do we set our settings for these anesthetics. They came out with a new agent called sevoflurane. And sevoflurane has a MAC of 2.1%. Now, I put a note here to the side, and I didn't put it by halothane. Halothane max setting is 5%. Isoflurane is 5%. The vaporizer to Sevo goes up to 8%, mainly because it has a much higher MAC. Its MAC is 2.1, meaning it is not as potent as iso. It's not as potent as halothane. But sevoflurane is the fastest induction and fastest recovery agent we have. So if I had a choice of these 3, and I was like, I got to mask a mean cat, I'm going to pick Sevo if I have an option. You know, in the world of teaching, we're going to pretend you have halothane, iso, and Sevo, even though you don't use halothane anymore. On a test, you have everything available. So in that scenario, Sevo has the advantage because it's very quick induction and it's very quick recovery. So, and the reason it has the fastest induction recovery, it has the lowest blood gas solubility. Oh, Shelby, 5%. Halothane's max setting is 5%. Okay. So sevoflurane, if I say which agent has the lowest solubility, it's Sevo. It doesn't get absorbed in the tissues. It doesn't get absorbed in the plastic. So pretty much when they inhale Sevo, it stays and is an intact molecule in the blood. Therefore, it's a rapid uptake to the brain. And during anesthesia, I can change the setting and I get even more rapid changes than I do with isoflurane. It's even more rapid. But let me say something about rapid as a clinical tip. When I started working with Niemer, and I knew Niemer did exotics, I was like, oh, I bet your doctors love Sevo. And she was like, my doctor hates Sevo. And I was like, oh, but it's such quick induction and recovery. The problem is when you have a high stress exotic patient like a rabbit or a bird, and sometimes you don't want them waking up quickly because they can potentially hurt themselves. They go from being asleep to like, what just happened to me? And you can get this excitement. And the problem was if they turned them down, they didn't like how rapid it was. And the other area where it's been maybe 50-50 is equine. You know, the problem with a horse is a horse, and we'll talk about this more in depth, but a horse does not like to be laying down. They don't like to be sedated. And the minute a horse thinks they're awake, they're going to try to stand. And a lot of times they're not ready to stand, but their brain thinks they are. And that's why a lot of horses can break a leg on recovery. It's a big, or, you know, they can hurt themselves. They can hurt you. I mean, I don't want a horse waking up crazy, but if 1,500 pounds wants to wake up, there's not a lot I can do about it, you know? So the nice thing about ISO was that when you turn off the isoflurane, it hangs around for a little bit. When you turned off the isoflurane, they would wake up much faster. So the thing is, it's a pro and a con. And what you guys will find in practice is that you'll have doctors that maybe had a case go bad on SIBO and they were just like burned. They're like, I don't want to do it. I don't want to use it anymore. Maybe that was just a problem with that case. But, you know, I've worked, you know, one doctor was like, I only want to use ISO. And this doctor's like, I only want to use SIBO. So you're going to get a lot of opinions. I'm going to give you a reason behind those opinions. And it's probably the speed is so quick. Like if you want your dog, like if I'm waking up an aggressive dog, I kind of want them asleep for a little bit. I don't want an aggressive dog like waking up. I mean, and maybe it had problems. If I have an animal that's critical, that was having problems under anesthesia, then I do want a rapid recovery. And you get the fastest change in their depth with sevoflurane. Now you guys will have this at school. We have both. We use isoflurane for the spay and neuters, and then we use sevoflurane for the dental. So you guys will get to experience both. But what you have to remember here is your settings are going to be different with, you know, again, because you're starting at a higher percentage MAC, it's, you know, the max you can go up to is 8%. It is volatile. It definitely needs a precision vaporizer, has a very high vapor pressure, minimal cardiovascular depressant, but I will tell you, it will still cause hypotension. When you get higher than like 4% SIBO, you're going to start getting into some really bigger side effects. Just kind of how I said, when you're above 2.5 on ISO, when you're above like 3.5, 4 on SIBO, you're going to see more hypotension, more respiratory depression. It's very dose dependent. But no organ metabolism like ISO, it's exhaled, so safe for liver and kidney dysfunction patients. And it's probably the best choice if you need a mask or box. So again, if I had all three available and you said, let's mask this guy or chamber, I'm going to pick SIBO because it's the fastest. Now again, it is the least potent because it has the highest MAC. But remember, speed does not equal potency, because this is the fastest induction, but the least potent. Halothane is the most potent, but the longest. So do you see what I mean? And that's kind of understanding those properties about those agents. So how do we use the agent? And I kind of started to explain this, but MAC is, you know, the literature will tell you at 1 times MAC, which is basically at MAC, your patients will be at about stage 3 plane 1. So again, and if you want surgical anesthesia, you have to do 1.5 times that MAC value, and 2 times that MAC will give you deep. So if I have isoflurane, here's my example. Well, 1 times 1.2 is 1.2. This is just simple math. If I want to do surgical anesthesia, 1.5 times 1.2 is 1.8. And then 2 times MAC, which is considered deep, is 2.4. Now, here's my note that these MAC values were established without anything on board. Okay, so I've told you guys, your pre-meds are MAC sparing. When an animal is pre-medded, you should need a lower MAC, but you're also probably doing a more painful procedure, okay? So for example, if I took a dog out and if I gave it a pre-med and then pinched its toe, I could probably be below this number. But the problem is we're gonna be doing like a spay. So you see what I mean? Like Pre-meds are going to help, but it's not going to completely drop that because it's a different type of procedure. So this is just a guideline. So let me explain what you guys are going to do in surgery. And this is my advice, but again, this is general advice. Every patient is going to be different. When so they're usually, we let them pre-med for 15, 20 minutes. We get them out. You guys put a catheter in. You're going to give the propofol. Let's say it's a dog spay, okay? You give the propofol. You get the intubated. Okay, remember, propofol is going to be gone in about 10 minutes. So as soon as they're intubated, you're going to hook them up to the breathing system and turn on your oxygen and your inhalant. So let's say we're using isoflurane. I usually start my patient at about 2.5%. Now, that will really vary depending on how deep the patient. Some patients are deeper. Some patients fight induction, but as a general guideline, and the reason I'm starting high, or 2.5%, think of it like a loading dose. If you've been in pharmacology, sometimes we give a higher dose to saturate the plasma and saturate the target tissue, and then you lower your dose. So if you start at 2.5%, then usually what I do is I'll evaluate my vitals, my reflexes, and get all your vitals, get a heart rate, respiration, check your jaw tone, what's your eye position, what's your color, get an assessment, how is your patient breathing, and then I may try to turn them down. And I always try to turn them down to the lowest amount. Now, I put a note about SIVO, because if you were doing a dental, I would probably start SIVO at 2.5 to 3% because it's a higher MAC, okay? And then you're going to do the same thing. You're going to reevaluate or look at your readings and then see if you can turn them down. Now, and that's a really good question, Bethany, because how do you change them? Generally, when you look at a vaporizer dial, it has it has a hash at like 1%, 2%, 3. And then in the middle of that, you have a little line, which equals 1.5. Sometimes I'll do either quarter to half increments. So like if I was at 2, I may go to 1.75 or 1.5. It kind of depends on how deep my patient is. Sometimes my patient I thought was way too deep. I've gone a whole percent. I've gone from like 2% to 1%. But generally you do like quarter to half increments. So, and we kind of call it stepping them down. You're kind of just going click, 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 and you're kind of like gradually taking it away. So since they're both quick, you can turn them up and down. And it's, again, let me give you a scenario. If I brought a dog into surgery and in pre-op, okay, where you guys are clipping them, their heart rate had been 120. And then you get, right before you move, they're 100. And then I get into surgery and their heart rate's 80. And then it's 72, then 65. So we've gone from the prep room from 120 and we're kind of sliding down. If that patient was at 2, I'd probably try 1.5, maybe 0.5%. And then Dr. Paul comes in and he starts cutting. Because the other thing to remember, it takes you guys a while at school to prep them, and they're under for a while without being stimulated, if this makes sense. Then Dr. Paul comes in, and the first thing he's going to do is he's going to look at you as the anesthetist and say, is my dog ready? I think I asked you guys this question on a test. I literally phrased it like Dr. Paul walks in, he looks at you and says, is the dog ready to go? What do you tell him? Well, if I have a stable heart rate and I've had stable respiration, I might say, go for it. And then sometimes he starts to cut, and then all of a sudden the patient starts to huff and puff because they've been laying there with nothing really happening. So now what I do is I may have to go up. Maybe I had gotten him down to 1.5, and he starts feeling the surgery, I'm going to go to 1.5 to 2 to maybe even 2.5. And then maybe he calms down, then I go back to 2. I mean, sometimes I'll tell you in that first, when you're first in surgery and when they first cut, that'll tell you a lot. But there's times, I know this one patient I was helping with, I had her get the patient all the way to 1%. The patient seemed fairly deep. Well, once she turned to 1%, all of a sudden the heart rate started creeping up. The dog started huffing and puffing. I was like, okay, go up to 1.5. And then 1.5 was our spot. We stayed there the rest of the surgery. So don't be afraid to turn them down and to try. And also you guys will have, like, it might be Mrs. Redmond or Dr. Ritz, or, they'll give you feedback. And it's okay to say, hey, do you think I should turn them down? I'm just not a fan of leave them at 1% and forget it. Okay. You always want to see if you can get away with the lowest amount. Another little tidbit. When I worked with when I worked up in Anderson and I worked with a criticalist, and we would have to take animals to surgery, and sometimes some pretty sick ones, but on emergency, his goal, he's like, I don't want my patients higher than 2.5% on, we were using SIBO at the time. And he's like, if you have to turn them up above 2.5%, we got to give them something, maybe some more hydromorphone. Because the problem is, remember, these gas anesthetics have no analgesic effect. They will keep your animal asleep and not moving. But the problem is, if your patient is reacting to something and you're having to turn them up and up and up, and sometimes I battle patients, sometimes I've had to have them at a higher percent, but most of my doctors will giving them, I'll usually just say, hey, I can't turn this patient down. He's huffing and puffing. I mean, I communicate to my doctor and they're like, yeah, let's give some more butorphanol, or let's give some more hydromorphone. Because you can give whatever you give in the pre-med, you can give a dog a little, and it's definitely not the same pre-med dose. Usually if we give it IV during surgery or intra-op, we typically will use a lower dose. Yeah, Bethany, that's the theory. His theory was we didn't achieve adequate analgesia. It may not be even that it's wearing off. It could be wearing off. But also maybe maybe that patient is more painful and we just didn't achieve. Yeah, it could be both. Now for you guys in surgery, just because I helped so much this term, sometimes it was 45 minutes to an hour after the pre-med by the time we were moving into surgery. Now you guys have seen them during radiology. You guys get about 30 to 45 minutes of sedation, right? If you use Dexdome and butorphanol, I know AJ, you guys were trying to do a few more rads and he was starting to move. And that was a little bit after the 30, 40-minute mark. So my point is kind of what you're leading to, Bethany, is like, if you gave the pre-med and now it's 45 minutes to an hour after the pre-med, yeah, some of that sedation, hangover, pain control is wearing off. And I've heard too many stories from students on externship and just people in practice where animals are at, like, I don't want to see vaporizers at 4 and 5%. If they are at 4 and 5% during surgery, there's something is wrong. Something you should be able to, they need probably more analgesia. I mean, there could be a problem with the vaporizer too, like there's a pathway to figure that out. But in that patient, kind of the first thing I'm thinking is maybe they're more painful. Maybe we didn't achieve adequate analgesia. So, I can't tell you there's a magic number for everybody. And I know as a student, you're like, just tell me what to do. What do you're going to have to start. This is my guideline. This would be an excellent handout for you to keep with you when you're in surgery, because this is telling you where you start and what is your goal. And again, your monitoring of your reflexes. I've told you how to tell if an animal is starting to get light or deep. And if you're starting to see like eyes are central, respiration is down, heart rate's down, jaw tone's loose, color is blood pressure, that everything's going down, then I would turn my anesthetic down, and then hopefully you start to, one thing, and probably haven't mentioned this, is when you have, well, I mentioned this when I talked about low blood pressure, when I talked about monitoring and I talked about low blood pressure, one of the very first things I do is I try to turn down my gas anesthesia. I do that usually before a fluid bolus, because a lot of times, just because these are so potent vasodilators, a lot of times just turning down the inhalant, the blood pressure would improve. Now, sometimes I will turn them down and give a fluid bolus. But typically, one of the very first things is you got to turn down your gas, because the higher they are, the longer they're on, is, that blood pressure is going to continue to go down. The other thing is, I talked to you guys about hypothermia. Hypothermia reduces your MAC value. Hypothermia acts like an anesthetic. The colder your patient, the less you better be turning down their gas accordingly, because theoretically they shouldn't need as much. Now, some people, when I ask this question on tests, they're like, well, put your patient on a heating pad, that'll fix the problem. Patients do not warm up as quickly as they go down. It's much harder to get them warmer, but then they get cold. They get cold really fast. So I always say work hard to prevent hypothermia, because just putting like a heating pad, rice socks, warm fluids, I've had plenty of patients that I've done that on, and their temperature just kind of goes beep, beep, like just tiny little increments, So you can't rely on warming them up to change them rapidly. I mean, always do it. If you have a cold patient, you got to get them warm, and that should help. But in the meantime, you have to do other things. You have to potentially turn down anesthesia, maybe fluids, while you're warming them up. Because again, that's not rapid. Nothing you do to warm up their temperature is going to do it quickly. So, do you have questions on this kind of the inhalants?
On that last part, when you were just talking about hypothermia, you said it lowers MAC?
Yes.
Okay, thanks.
Yeah, it kind of acts as a secondary anesthetic. So, that's why, let me bring up a point. It's kind of like if kids fall in an icy pond, how kids can survive being submerged in cold. It kind of, it slows the metabolic rate. And if cold slows the metabolic rate, you shouldn't need as much anesthetic. So if I'm battling temperature, I'm usually trying to turn down my inhalant, and then monitor your vitals. If the heart rate goes up and blood pressure goes up, you have to turn them up. But usually hypothermic patients, you can usually turn them down pretty good. Kayla, the final, what I mentioned at the beginning was going to be Thursday after class. We'll meet Thursday and do a review, and then it'll be open for like a chunk of a window, like after class, maybe till like 6 or 7. Yes. So we will meet Thursday. And Heidi, you can ask a question. If I'll do this, if you don't have any questions, tomorrow I will pick up on the vaporizers, and you're free to go. But yes, Heidi, you can go ahead and ask your question.
So I have a question about on number 13 on the homework. It said, is nitrous oxide an inhalant like sevoflurane? I can't remember us talking about it, so can you kind of explain that again?
Thank you for reminding me about that, because this handout doesn't go over nitrous, and I probably need to get back in the PowerPoint. Nitrous oxide is a medical gas, and it does have a sedative effect, but it's not a volatile agent. So nitrous oxide is delivered via a tank, almost like you would hook up an oxygen tank. And nitrous oxide is used the way we use it in veterinary medicine is we use it as an adjunct. So I did it a couple times at Purdue. I would have a patient on oxygen and halothane, and then I had a tank of nitrous hooked up, and I would turn on a little bit of nitrous. But nitrous was, yes, so it enhances analgesia and it lowers your inhalant. So if I had a patient on halothane that I was trying to lower the amount of halothane, but I was having trouble, I could add in a little nitrous and it would help enhance analgesia. It's very short-lived because the minute you turn it off, they're going to feel something. So you would still have to pre-med, but it was used to reduce your MAC. But you had to give it, it was never used by itself in veterinary medicine. I know people get it at the dentist, but that's different. In veterinary medicine, we would add it into, like, with our oxygen and inhalant. And it's not a carrier gas, so you can't use it to deliver anesthetic.
So it's not something that's commonly used in veterinary medicine anymore.
I don't know if anybody will ever use it. There may be some specialty type practices or teaching hospitals, but you probably will never use it. It could be on the board exam, so that's why I just mention it. And again, I used it so long ago when I was at Purdue, but yeah. So and probably research you might, but for your everyday average practice, probably not going to use it. I don't even think we have it at VCA. So, and they do brain surgery there. So we do some pretty advanced surgeries at VCA, and I don't even think we're using nitrous.
Oh, okay.
Does that make sense? Sorry, I'm glad you brought that up because I kind of skipped to this handout and I think I glazed over nitrous a little bit. So thank you for bringing that.
Well, when I was doing the homework, I was like, I'm not sure what the answer to that is because I don't remember discussing.
Yeah, I mentioned it kind of at the beginning. The main difference, like I said,
How it works.
It comes in its own tank. It's inhaled, but it's not an inhalant. It's considered a medical gas, and it's used to enhance the inhalant anesthetic. So I kind of call it an adjunct because you're using it with, and it competes for oxygen. So you definitely, you can't run too high of amounts because you can make them hypoxic. It competes for the air sacs in the lungs, and it can displace oxygen. So you have to deliver it a very precise way and make sure they're breathing okay. I'll give you an example. If I was running a 1 liter flow of oxygen to my patient, I might do 0.8 liters oxygen, 0.2 liters nitrous. So I have 100% total, but 80% of that is oxygen and only 20% of it was nitrous because you had to keep the oxygen higher than the nitrous. I would never even run them 50-50 because there's such a competition for nitrous will bump oxygen out of the lungs and then they can go hypoxic. So it's delivered very carefully. So hopefully, and I can talk about it more tomorrow. And like Bethany said, yeah, it's analgesic. It's used to enhance agents adjunctively, not as a primary. It's never, in veterinary medicine, it's not a sole agent. I know we get it at the dentist by itself, but that's a little different than in veterinary medicine. Okay. Thank you for asking that. Okay, tomorrow, maybe mention that to me and I can talk a few things about it in the beginning before I get into vaporizers. All right, I'll post this video and I will see you guys tomorrow.